I'm really happy to come to you today with our guest speaker, Chet Villa. I've known Dr. Villa for a very long time. He's from Cincinnati Children's Hospital, and he, along with two other colleagues, are leading a network called the Action Network. Welcome, Chet.
Thanks so much, Pat.
Would you just give us a little bit of your background as we start, Chet?
Yeah, so I am originally started as a heart failure transplant and VAD or ventricular assist device doctor here at Cincinnati Children's. And as my career evolved, I got more and more interested in the neuromuscular clinic and especially in the care of patients with dystrophinopathy. So it started when we put our first VAD into a man with Duchenne. And that kind of really introduced me to the community. And since then, it's only really gone up and up and up in terms of my interest.
Well, thank you. And we've been very interested in the heart for a very long time. And selfishly, I think, I am. My son's died of heart failure. So I'm very interested in making sure as we are able to use interventions that prolong ambulation and skeletal muscle function, that we make sure that that heart is built to last. So you and colleagues have carved out a Duchenne into the Action Network. Can you give me the broad, what is Action? And then what did you do about making Duchenne a part of that?
Yeah, so Action started as a group of 5 to 7 hospitals interested just in heart failure in general and specifically in VAD. So it was started out of Cincinnati Children's and out of Stanford, Lucille Packard. And we thought we were going to do a great job of just having a couple of centers. And then once other centers started to hear about it, they said, oh, I'm interested. And now it went from, we would have been excited for about 10 centers to now more than 50 centers. And that initially focused mostly on VAD and heart failure in general. And since then it has expanded to a couple of different areas. One of those was Duchenne specifically, and now more broadly into dystrophinopathies in general. So I think much like what happened from a heart failure and VAD perspective, we had a couple of centers interested in the beginning from a dystrophinopathy perspective, and now we're up to almost 30 centers that are engaging, helping us put together consensus documents, helping us to collect clinical data and moving forward from a research perspective.
So when you're talking about dystrophinopathy, you're talking about Duchenne, Becker, and female carriers. Is that right?
Yep, that's exactly right. Yeah, and we use that term because I think for a lot of families, Duchenne was overshadowing a lot, but we were seeing a lot of Beckers and more carriers were coming into our clinic. Either they were accompanying their brothers and they were saying, oh, I had these feelings, or what should I be doing? And our answer for a very long time was, we don't know. And I think a significant part of what I enjoy about my job is being able to actually treat the whole family in a variety of ways. That in terms of anxiety, what are we all going to do to work together to optimize the care of your son or brother? And we were realizing we were doing a disservice, I think, to a lot of mothers and daughters and those who have Becker, and just saying, we just don't really know. We don't have a community to kind of put that together from a cardiac perspective, especially for those communities in particular. Cardiac disease is their predominant manifestation. They may have some weakness, but cardiac disease, especially for Becker's and for a number of carriers, is the thing that they will see more often than the skeletal muscle. So we said we need it all together. We need to be able to treat it all together. We need to think about it together, and we need to move forward that way.
Well, that's pretty amazing. I know that female carriers have often been dismissed by physicians saying, you're just fine, when in fact they do have some manifestations, especially in the cardiac arena. So are you hopeful with the Action Network, and we're thrilled to be able to support them? Are you hopeful that all of these centers will get together and develop consensus about when do you treat, and with what do you treat, and what age do you treat?
Yeah, so we've just started with that. And what I say about cardiologists is it's like herding cats, right? If you get 5 cardiologists in a room together, you'll get 7 opinions on what you should do. And that is a real challenge, not only for us to move the field forward, but also for families, because if you get care or second opinions at multiple places, it's very challenging, I think, for families to be able to parse that data, understand why one center would recommend one thing over the other. And I think that's extraordinarily difficult in an already challenging situation when you're trying to do things as fast as possible. And so we've already started this. We began with the 3 basics of cardiac medications. So ACE inhibitors, ARBs, mineralocorticoid receptor antagonists, that's like spironolactone and eplerenone, and then beta blockers. So we started with, I think, the 3 medications that are most commonly used, and now we've expanded it to 5, including new cardiac medications, which we'll talk about. And we are now moving the next step, and we hopefully should be coming out with this relatively soon, about how we do things like rhythm monitoring, how we do cardiac function monitoring, how do we incorporate MRI, if you can incorporate MRI at your center, because we need this to kind of come together, both for clinical care, but also the untold story there is also for research. If we are doing things in a similar way, it will make it easier for us to answer the fundamental questions of how heart disease progresses and what we can do about it. If everyone's doing something differently, it's almost impossible from a research perspective to make sense of those in a short time period.
And why do you think cardiac MRI is so important here? What is that the most important tool in addition to or outside of heart monitors and other tools?
Well, I think we've got a couple of different things that kind of overlap there. First, I think we've started to steal a saying that I learned as a medical student from adult cardiologists who are treating heart attacks, which is time is muscle. So you have to understand how the disease process is progressing and when it has begun. Otherwise, you're going to miss windows for earlier therapy. And that has been known by the neurologists for a long time. As a cardiologist, we're only starting to pick that up. Right? Neurologists have really started to push in terms of, here are the different ways that we assess all of the different muscle groups. We evaluate it over time, and we do it in a very granular way. For cardiologists, we were using basically the very most basic tool, which was echocardiography, which is really important for tracking large changes. But we know outside of dystrophinopathy that echo is less accurate than MRI. And 2, the really important part from an MRI perspective is it tells us about tissue. We know, just like in skeletal muscle and in respiratory muscles, that the disease process begins before we actually start to see dysfunction. And that's a really important therapeutic window, right? If time is muscle, the earlier you detect those changes, the earlier you start therapy, the better the long-term outcome. Because we know, based on tissue autopsy data and MRI stuff, that once those changes happen, what we're just trying to do is preserve muscle. We can't make it come back from a cardiac perspective. And so detecting it earlier is fundamental to improving your long-term outcome by getting you on the right meds at the right time.
You think there'll be a day when at diagnosis we begin cardiac medicines to prevent change?
I think there may be. I think we're not there yet. We are pushing earlier and earlier based on some of this data, especially MRI data, to say, hey, we're detecting earlier changes. And so we're starting meds now. The recommendation is at 10 or earlier if you have evidence of cardiac dysfunction or LGE or late gadolinium enhancement, that SCAR by MRI. But there may be a day as we get more and more data where that happens. I think we're not quite there yet, but that's also why it's so important to have multi-center studies, because even at the biggest centers around the country, you cannot answer that. We don't have enough numbers, because we need to be able to track boys and men through the school age years into their teens and into their adulthood to really be able to detect those differences. And so I think that speaks to a couple things. We're not quite there yet, but I think we're building the apparatus to do it. And I think it will start to be a real question. We just don't have an answer yet.
And how do you think about those newer medicines that we hear about, Entresto, newer in terms of pediatric use, not necessarily newer, finerenone, the SGLT2s, such as used for diabetes, but seem to have benefit on the heart? As a parent, you want to, sometimes it's more is better, right? If we throw all these things at the person we love, maybe that heart will last longer. So how can we as a community think about that?
Well, I think that goes back to one of your first questions about standardizing care or harmonizing care is probably the better term, because no boy is the same, but we have to kind of condense around where the data allows. So a couple of things. One, I think we really need to understand how those make a difference in Duchenne. And I think we do so in a timely fashion. One of the biggest studies that have come out in the last couple of years came out of France. It took them about 20 years to get enough data to show that starting ACE inhibitors prophylactically made a long-term difference in terms of heart failure. That's too long. We need to understand how these medications work over the short term, medium term, and long term. Short term, we need to understand and make sure they're safe, first and foremost, because none of the studies that involved those drugs included patients with any kind of muscular dystrophy, and especially no Duchenne or Becker. In fact, there were often reasons you couldn't be in those trials. So as a result, we need to understand safety. That I think we can do through action, because we're collecting how people are doing with those medications. If they have to come off, what are the complications that are coming off of that? And then over the 2 to 5 year term, do those make a difference in terms of cardiac function, heart failure, all that sort of stuff? Again, I think that's the nice part where I can say, I think your support, and not just on a 1 year basis, at PPMD, is allowing us to collect in that 3 to 5 year range, so that we can start to answer, one, is it safe? And two, does it appear to be effective? Because we need to understand that now. We can't wait another 20 years to be able to say, oh yeah, it turns out SGLT2s are great, and we missed 20 years.
Right. Time is muscle, right? And time is heartbeats, and time is the commodity here in this community. And it matters that we try to move as rapidly and as safely as possible. So just thinking about cardiac MRI, I know it's not available everywhere, but sometimes we see families who get a cardiac MRI at 3 different institutions and have 3 different readouts. And that too is confusing. How do you manage that? And is there a way to standardize that cardiac MRI read?
Yep, I think that we can do. There are so many different bells and whistles, and MRIs. I just think about my phone. Every year I buy a new phone, it can do new things, it can try all of these things. And we often don't know how to incorporate all of that into our daily lives. MRI is the same thing. With each generation of MRI, it can do new bells, whistles, all that sort of stuff. We need to understand how those work over time. But more importantly, we as a community, as a cardiology community, as a research community, and with regulators, need to say, here are the fundamental things that need to be answered on every MRI. We need that from a research, natural history, and from a therapeutic perspective to see if it makes a difference. If we agree on all of those things, great. You can do all the other bells and whistles, but here are the components that we need to collect from a cardiac perspective. Here are also the ones that families will want to hear about, because they know why we care about those. And then if you get all these other bells and whistles, great, awesome. That's just bonus. But we need to define what are the things that matter most from a disease perspective and from an outcome perspective. And I think we're working on that through our imaging group. So Dr. Soslow down in Vanderbilt and others, Dr. Khan Hoare, are working on that, I think, to try and make sure we as a community come together and define what we think are those important things, and that we update those. As those new bells and whistles come along, if there's something that says, oh no, this is better than the old way that you do it, we need to update that in real time or semi-real time. And we need to feed that back to the community, so you can go to your cardiologist and say, here's what they're doing in these other centers. Are we doing that? Or no, if no, why not? And what can we do to kind of push things along?
Yeah, I think we're hearing about core data sets, right? In cardiac core data sets and skeletal muscle function, because as people add data to the EHR, the health record, if it's inconsistent or all over the map, then we can't really look at the data. So I think having core data sets in cardiac and skeletal muscle, and maybe one day smooth muscle, would be pretty terrific. A little bit of a pivot now. I will say, I know young men one young man in particular who's now traveling around with Becker with his VAD. But I have to say, sometimes just the concept of VAD feels very frightening, and the discussion of what you're going to do based on where the significant heart failure. Can you talk us off the ledge a little bit about VADs and your confidence in them?
Yeah, so I think first for families that don't know what a VAD is, so when your heart is not functioning well, and we've tried all the cardiac medications we can to try and keep you out of the hospital and keep you doing well, unfortunately, if those are kind of at their limit, what we have to do is implant a mechanical pump. So what happens is, what that does is it takes blood out of the heart. It is surgically implanted, so they actually have to go through the chest wall, put the pump into the heart. It pulls blood out where your heart is supposed to be pumping, but can't quite do it because it's too weak, and pumps it out to the body. So that pump is powered electrically, and there's a little line that comes out your stomach to be able to take control of it. And so it does and helps your heart in a way when it's not able to do it anymore. So these first began to be implanted in patients with Duchenne about 15 years ago. And there were only a couple of centers that were doing that because people didn't know if it would work. As more and more centers started to gather experience, we could see that in some men, especially those who heart disease is their predominant problem, and their lungs are pretty okay, and their skeletal muscle function is pretty okay, and they have support, that these pumps could keep them out of the hospital, and they could keep them feeling better for longer. Okay, that's the good part. The challenging part about these pumps is, one, you have to undergo surgery, and two, you have to be on blood thinners for the rest of your life because it's something that's artificial and stays in your heart. And those pumps are getting better, just like we were talking about with MRI or with phones and other stuff. The newest pumps that have come out in the last 5 years are the best yet. The 2, 3, and 5-year outcomes have been way better than anything that we've seen before, but it's still a big surgery. It's still a big challenge. And even though we're learning more and more, especially over the last 4 years, we've seen a significant increase in the number of patients with Duchenne and Becker who have got these pumps. We're still in the early phases of learning. And so what I would say is, one, it's good to have an option. 10 or 15 years ago, you could probably only go to 5 centers around the world to even have this as an option. Now we're seeing more and more centers learn that this is feasible. So it will give you options where you live. I think that's the first part. And two, we're going to learn how to do this better. Okay. It is always going to be scary. It's always going to be something I wish I wouldn't have to talk to families about. But until we actually cure heart disease, it's something that's going to need to be a part of care for men, especially as they do better from a lung perspective and from a skeletal muscle perspective. And so what I'd say is let's value the success that it's now an option for some people. And two, let's get better, because it's still a challenge. It's still not right for everyone. And we need to get better.
And if I was at home with my son with a VAD, what kind of care do I need to think about? Is this a 24/7 I'm staring at a VAD, or how is it managed in the home?
Yeah. So I think this is one of the areas that we're really starting to focus on, because if the pump works and makes your heart do better, but you can't go to school, you can't work, you require an increased level of care on top of what already exists from a Duchenne perspective or from a Becker's perspective, then the quality of life is not really there. And if that was the case, there's no way I could come to a family and even talk about that. I think that is not the case. One, you have to have an individualized evaluation for this. So families need to learn, here's what's going to be different about the VAD, and it's going to be different for every boy based on what their level of skeletal muscle function is and lung function. And so I can't give hey, here's what it's going to look like for every boy, but you need to get a comprehensive evaluation, because as you said, for some people with Becker's, after they recover from their VAD, if they don't have complications, they go back to work, they drive, they do all of those other things. From a Duchenne perspective, it's going to require some additional medications. It's going to require some differences in how you might move your son, especially if they're weaker. But from our perspective, I will say for the patients who are out now more than 4 years, knock on wood, right? We've had patients who are now out of the hospital for a very long time. We're finding ways to keep them out of the hospital. They come back to our clinic about at least once a month. They have to get blood work to make sure that their drug levels, their blood thinner levels are where we want them to be. But otherwise, they're going to grocery stores. They're going to movies now. They're doing other things. But there are some additional challenges that need to be talked about with your team. But I think the quality of life, especially without complications, is very much there for these pumps. And it's giving us an option we did not have 10 or 15 years ago. People were just saying no in the beginning because people had muscular dystrophy, instead of looking at the boy or the man in front of them and saying, okay, what's their lung function? What's their social support? And can this work? And I think we're learning for some families and for some boys and men, yes, it very much can work.
That's pretty amazing. And last topic, at least in this section, is what about transplants? I know that hearts are not simple to find, but in the past, Duchenne hasn't been eligible for transplant. I believe Becker is, and I've even heard that some female carriers have been transplanted. So can you give us a little bit of a view toward transplant in Duchenne?
Yeah, I think it segues in actually beautifully from a VAD perspective. You have to look at the boy and the man and the family or the woman in front of you. Just like VADs aren't going to be right for every man with Duchenne, even if their heart is failing, transplant won't be either. But what we can't do as a community is say, here's the diagnosis, and the moment that diagnosis comes across my desk, they're not a candidate for VAD or for transplant. That's not right. Because I know some men with Duchenne who are getting into their late 30s, early 40s. Some people have great lung function. Some people have not good lung function. Some people have more upper extremity strength. Some people have less. You have to look at the person in front of you and assess, do I think that this therapy is going to work? We cannot use a diagnosis. And I think that's especially important in the current era, where steroids, where exon skipping, where gene therapy comes along. It turns out those diagnoses are really starting to blur in an era of new therapy. And so the answer for me from somebody who does heart transplant is the diagnosis doesn't matter. The man in front of me does. What's their heart function? What's their lung function? What's their social support? What can we do to make sure if we put a heart in that they're going to continue to do well? Because if we put a heart in to somebody who doesn't have great lung function, has repeated infection, has other stuff, putting a heart in actually will be the wrong thing. They will actually do worse because they have to go through the surgery. They have to recover. They're at risk for infections. We have to look at the boy and the man or the woman in front of us and say, is this right? The diagnosis shouldn't determine that. The person should.
I totally agree. The person determines that. And I'm really glad that you said you don't look at diagnoses, because so many times you're put in a box with a diagnosis, and then depending on who's giving information may not be all the options that are available to you. So I can't thank you enough. We're so happy to support the Action Network. I think it's brilliant, and I'm really looking forward to all we can do together to make sure our hearts are protected, all of them. Thanks, Chet.
Thank you so much. I think the support, we couldn't do it without you and without the families. I think, as you heard me say in answer to multiple of the questions, the only way we're going to answer these questions in a timely way is by working together. And without your support and without the support and tenacity of the families, I don't think we would be able to do this, or I know we wouldn't be able to do this. So thank you, both to you and for the families.
We have a good village. Thanks, Chet.
Thanks so much.